Hello, welcome everyone. Thanks so much for being here. We're excited to start this webinar on how technology can support your journey toward integrated care. We're just going to give a few moments for other attendees to make their way. I can see we went from 25 to 480. So while we're waiting for folks to join us today, my name is Solomay Tibabu. I'm the founder and host of Going Digital Behavioral Health Tech. I'm so excited to be joined by some amazing leaders who've done incredible work as it relates to integrating behavioral health and physical care. So excited to share all of your perspectives today, but just some housekeeping items. We're going to go through introduce folks, have a discussion, and there is going to be an opportunity for live Q&A at the end. So please, at the bottom of your screen, you'll see that there's a Q&A button. Feel free to submit questions as they come, and by the end of the talk, we'll be able to pause and take 10 minutes on those. I think without further ado, I think I'd like to get started with some introductions. So how about in order of what we see here, starting with Frank, Casey, Tom, if you can just share name, role, company.
Sure. Thank you very much, Salma. Great to be here. Frank Webster, Chief Medical Officer for Behavioral Health for Blue Cross Blue Shield of Texas, but also we have 4 other states, so Illinois, Oklahoma, New Mexico, and Montana. Background is emergency and community psychiatry. Also teach health informatics as well. So very excited to be here. Really role is basically the behavioral health operations, behavioral health strategy for our Blues.
Awesome. Casey.
Hi, I'm Casey Kelly. I am the Chief Innovation Officer at the Meadows Mental Health Policy Institute, which is based in Texas, where we lead nonpartisan policy and implementation efforts so that all Texans have access to high quality behavioral health care when and where they need it. And our goal is for Texas to be a leader nationally in driving reforms across the country.
And I am Tom Zaubler. I'm a psychiatrist and the Chief Medical Officer at NeuroFlow, which is a company that provides an integration of behavioral health and psychiatric services into medical settings. Prior to that, I was a department chair for 21 years and have been immersed in the world of collaborative care since my fellowship with the founder of collaborative care, Wayne Caton, back in the 1990s. Pleasure to be here. Thank you for having me.
Awesome. Well, as I said, I'm joined by some amazing leaders who have done so much work as it relates to integrated care for mental and physical health. Why don't we just jump right in? I know we've got some folks joining us, but to keep the ball rolling here, Tom, I'd like to start with you. So you've spent your career enabling the integration of behavioral and physical care. Help our audience understand a little bit more about what actually that is and why is it important at this specific moment in time?
So thanks for that question. And let me take a second just to level set a little bit, and it will underscore why it's so important to address this issue. So many of these facts I'm about to state, we're all very familiar with, that about 20% of the population struggles with psychiatric illness. That's over 50 million people. We know that depression is a leading cause of disability worldwide. We know that 50% of all cases of psychiatric illness start before age 14 and 75% start before age 24, that suicide is a leading cause of death between those who are 10 and 24 years old. And what is particularly striking is that with that prevalence, psychiatric illness drives medical illness, increased costs 3 to 4 times when you compare people without psychiatric illness, without medical and psychiatric illness co-occurring with those just with medical illness. The costs are substantially higher, well over $300 billion annually in increased medical costs. So highly prevalent, highly disabling, and very costly. And what is so striking is that when you look at how we deliver mental health care in this country, 95% of all mental health providers are practicing in siloed settings, inpatient settings, outpatient mental health settings. And yet, when we look at how patients present with their psychiatric problems, roughly 80% either present primarily or exclusively in medical settings for their psychiatric care. So there's a huge disconnect here in terms of where people are seeking care and where the care gets delivered. And part of the challenge is how can we rebalance that so we can provide care to those who need it in a way that makes the most sense. We know that in primary care, there are huge challenges in managing psychiatric problems. Primary care docs have a very limited amount of time to spend with patients. They have limited amounts of experience or expertise, and the challenge is overwhelming. So depression gets lost about 50% of the time, even when the diagnosis is made. Only about 20% of those 50% of patients that are diagnosed actually get better. So the reason that integration is so important is that our primary care system and the medical system in general is de facto the mental health system for this country. And so it's absolutely critical that we provide integration of psychiatric and mental health services into that setting. And one of the challenges is that the workforce is so slim in terms of the ability to manage these problems with behavioral health experts that we need to look at that along population health models. And they do exist. Collaborative care being one model that is highly evidence-based, that looks at integrating psychiatry and behavioral health into different medical settings using a clinician integrated in a practice. The primary care doc is doing the prescribing and leading the team, and a psychiatrist providing what is referred to as caseload supervision. Psychiatrist isn't actually seeing patients, but meeting with the clinician in the practice who's providing therapy and care coordination on a weekly basis. And it allows that psychiatrist to go through a much larger caseload of patients than if they were seeing patients individually. And there are many variations on a theme in terms of what behavioral health integration can look like. Collaborative care being the modality that has been the best studied with over 80 randomized controlled trials looking at its efficacy. But there are lots of other variations on that theme of behavioral health integration that can be employed and are successfully employed in many different settings, primary care, quaternary care, a range of different settings. So that gives some background in terms of why it's important, and I'm sure we'll go into more detail in terms of the types of care that can be rendered through behavioral health integration efforts and technology as well.
That's great. Thank you so much. Yeah, and Frank, I'll turn it to you now. Blue Cross Blue Shield of Texas has been pretty progressive as it relates to pursuing integrated care and perhaps even the collaborative care model. Can you tell us a little bit more about what kind of work has taken place?
Sure, thank you very much. And I just want to agree with what Tom said about the integration collaborative care. It's really critical. And I would add one more piece, which is measuring care and measuring clinical outcomes. There are free, nationally validated instruments available for like depression, like PHQ, Patient Health Questionnaire, GAD-7 for anxiety, that just the act of measuring helps improve outcomes. And so one of the things that we've been working with our, whether it's behavioral health practitioners or medical practitioners, measuring makes it better. Andy Keller, who's president and CEO of Meadows Mental Health, likes to talk about, look, we measure blood sugar, we measure this. Why are we not measuring when we're treating in behavioral health? And he's absolutely dead spot on that. And so we've been really working with both our primary care groups and our behavioral health practitioners to make sure they understand that you can actually be reimbursed for these things. One of the things that I still do a little bit of clinical work, hospital rounds and weekends, and about a half an hour a week of clinical. The clinic I work in, they were doing all these great standardized assessments, which is wonderful because it's better care, but they didn't know they could bill for them. So I'm having to it took about 9 months of conversations with the medical group manager to finally get them to understand you can bill, you should, because it helps us in the insurance end. We don't necessarily get the numerical results, but knowing that you're measuring care helps us understand that you're doing what you're supposed to be doing. This is what we want to see people do. So just raising the conversations on measurement-based care alone, and when we're talking to providers who are interested in value-based care arrangements, if you're not measuring outcomes, I don't have a conversation for you, quite honestly, at this point. This is really critical. It's just fundamental. It's simple. It's straightforward. It's easy, and it should be done. There's talk about making this a quality improvement measure along the lines of NCQA and the HEDIS measures, which it should be. The other issue is collaborative care in general. Now, collaborative care, because it is a more formal model, it's a little harder sometimes. Not every primary care group is set up to do this yet. Some of the groups that we talk to, they have somebody who's done collaborative care in another setting, and they are super excited. It's like, when can we start? Others are like, what's that? And there are less what's that conversations today than there were 3 or 4 years ago. But a lot of it is literally having conversations. And then you have groups like NeuroFlow who have technology that allow kind of easy plug and play for collaborative care practitioners. But getting the primary care group together with the people who are doing collaborative care, because even if the primary care groups tend to want to do it, they have no idea who to talk to. And so what we have literally been doing is kind of old-fashioned. Oh, you need to talk to these people. Let us arrange these conversations, because our role as a payer is to make sure that the codes pay correctly, which we've verified they do. The problem isn't paying for them. The problem is that people don't bill them, which means essentially that these things are not happening. So making people aware that this is financially viable, making people aware that this is something you can do and it's actually good. We want to pay you more to do this kind of stuff is huge. And one last comment, in the pandemic, we certainly saw self-reported rates of depression and anxiety go up by 340% or so. We saw suicide, substance use, domestic violence go by 30-40%. Prior to the pandemic in 2019, Blue Cross Blue Shield, any of our states, we were less than 1% of virtual visits. Over the course of 6 weeks, we flipped to almost 60%. We're still over 50%. That is just us getting out of the way and making sure the providers know they can and that they're going to get reimbursed for that. That was critical. And we had been pushing virtual visits but nobody listens when we say it, right? But the fact is, when it was needed, one of the big benefits from the pandemic is the fact that virtual care is now commonplace and people are used to it and accustomed to it. Because the other issue is that a higher percentage of people keep those virtual appointments and face-to-face. So we saw a growth of about 20 or 30% in total volume during the pandemic. It wasn't enough, but if we were still depending on face-to-face office visits, our same provider community could not have accommodated 20 or 30% more volume.
Excellent. Really great insights. And now, Casey, I'll turn to you. So Meadows Institute has worked with health plans amongst so many other stakeholders to shepherd and implement integrated care. Tell us more about the work that your organization is doing and what are you hearing now?
Yeah, thank you, Salome. And, I will say we are working with health plans. This is something that is infrastructure, and it's an infrastructure change that needs to happen. And it's getting a lot of attention both in Congress and across our political spheres at this point. In addition to the senior executives of health plans, as well as the policy institutes across the country, and technology companies, which I think it's really great that you were able to pull those key stakeholders today for this session. Through our role as part of being on the steering committee of something called the Path Forward for Mental Health and Substance Use. The Path Forward is the only national collaborative working to harness the power of healthcare purchasers to drive innovation in behavioral health care. So think large employers who are having to make decisions about benefits packages for their employees. So we're through that work, we are able to work with health plans to really understand what are some of the challenges that they're seeing from a payer perspective. We bring in, along with some of our partners, the mental health expertise. The American Psychiatric Foundation, for example, is the American Psychiatric Association Foundation is also one of the partners, and really try to collaboratively partner with them to identify where there are opportunities to make change on a national level, that then could trickle down to provider networks across the country and consumers. We do see, and we have acknowledged along with our partners in this work that we have a workforce challenge, and we have a network adequacy challenge when it comes to high quality providers. And so there's been consensus that integrating behavioral health in primary care settings is the way that we can today, in the near term, start to offset some of those challenges. In addition to that, in Texas, we've had really a great privilege of being in a position to help healthcare systems on the ground implement the collaborative care model, specifically in primary care settings. We're currently working with 18 healthcare systems across Texas, and over the next 5 years, hope to be in all healthcare systems. And we are not only primary care settings, we're also have a couple of opportunities to start working with pediatric settings as well. And, you've heard both of the other panelists talk about some of the startup challenges associated with implementing collaborative care and integrated care specifically. And so that's exactly what we do. We come in and oftentimes leverage philanthropy to offset those transition costs or those startup costs, to then help the practice with the operational workflow changes that need to happen, help them understand what changes with billing and reimbursement they need to make, and sort of overall model and practice changes. And it's exciting and it's hard, and every healthcare system is different because you have a whole different set of challenges if you're working with a big healthcare system like Baylor Scott and White or the UT healthcare system versus some of our rural healthcare systems and the community-based outpatient programs. So,
Fabulous. I know we're really getting into the opportunity of integrated care, and specifically collaborative care model, and how can we scale care in light of our ecosystem and shortages right now. I want to take a moment to remind folks that Q&A box at the bottom, remember, feel free to drop in your questions there. We'll be capturing them throughout the webinar, and we'll address them later. But let me go back over to Tom. One question that we got frequently on our registration form, we had asked, what are some of your biggest challenges when it comes to implementing integrated care? And something that came up a few times was with folks in large systems, how do you really implement behavioral health integration at scale? Do you have any thoughts on that, given your experience?
Sure. Yeah. So first of all, collaborative care, even though it has been around for a while and there are over 80 randomized controlled trials, it is still not widely adopted. Getting better. But it's a very different workflow and a very different way of providing care for patients with psychiatric problems. So I think, first of all, there's a learning curve, and there's often some trepidation because among primary care docs or other physicians, because this can be done not just in primary care settings, about prescribing psychotropic medications. What happens, and in my experience, and I think most others who do this sort of work, is that once these programs are put into place, the primary care docs or the physicians doing the prescribing realize there's a tremendous amount of support, that there's clinical decision support, and some of those fears really start to vanish. And in fact, it's really looking at not just the triple aim, but the quadruple aim of healthcare, and that it's unburdening the providers, because once you start providing a mechanism to care for these patients that take up a disproportionate amount of time and space in the medical setting, it's that 20% of patients who are the highest utilizers, accounting for 80% of all healthcare costs, or the top 5% of patients accounting for 50% of all healthcare costs. So it's, once you can really start to target those individuals who are at tremendous need, who are consuming an extraordinary amount of care and time, it does unburden the system. There are financial offsets, and it unburdens the physicians. So that's one barrier, is the anxiety about a new way of doing things, and disrupting workflows. There are challenges also in terms of setting up these programs, because there are costs associated with it. And while in 2017 G codes came along, and then in 2018 there were CPT codes that actually many of the major insurance carriers now pay for, not all, but many do pay for. And that has made a difference. The real extraordinary savings and benefit are the cost savings because of decreased medical utilization, ED visits, medical inpatient stays, in addition, of course, to quality of life improvement and all that. There are tremendous offsets. So you see in any health system that is looking at value-based care, and has risk contracting in place, they are often very eager to adopt these technologies. But where that isn't the case, and we're still mostly in a fee-for-service world, there's apprehension. And then the other piece of this is it's very challenging to scale this in a health system. Having done that, I can tell you that between the costs, between the horizon that often CFOs of health systems have, which is maybe a year out at most in terms of looking at the ROI, and often you don't see that ROI for 2 or 3 years. So there are challenges to scaling it financially. There are challenges to scaling it in terms of the workflows and how do you screen patients. It takes a lot of time when you're doing pen and paper assessments. And to Frank's point, I mean, collaborative care is truly a measurement-based care approach. No one falls through the cracks. There is universal screening for psychiatric illness, and then there's ongoing screening to make sure that patients are getting better. If they're not getting better, it's a stepped care approach so that the care can be shifted, whether it's a psychotherapeutic modality or care coordination, or the medication needs to be adjusted or replaced. There are changes that occur if patients are not getting better, but it's very time consuming. And then it's also, how do you identify if you have a lot of patients in a primary care practice who are scoring positively on these assessments, PHQ-9s, GD-7s, how do you figure out which patients really need the most attention and which patients are most at risk? You can do it, but it's very challenging when you're using pen and paper tests. And I think we'll probably get into this a little bit later on, but this is where technology can play a huge role to automate some of those workflows and to provide remote assessments of depression and anxiety from the convenience of one's phone or in their homes, or in kiosks or tablets that someone can enter their PHQ-9 and GD-7 scores, and they populate directly into a registry that has interoperability with the EMRs and so on. So this is where I think technology can provide tremendous opportunity to scale these programs. But those are some of the challenges.
Mm-hmm. Yeah, it's a great list. I think, Frank, maybe I'll ask you from the payer's perspective, what are some of the challenges in terms of taking steps toward integrated care as a health plan?
Well, as Tom alluded to, there are kind of operational on the ground issues, right? And then on the payer's standpoint, there's mental health, behavioral health costs on a commercial insurance are 3 to 5% of healthcare costs. So it means 95% aren't behavioral health. However, as been mentioned, those 3 to 5% of costs can have a huge impact on medical costs. Getting people to understand that, because if you just look at it in a spreadsheet, behavioral health just doesn't look important because it's small. And that is always one of the issues, whether it's an insurance company or you're in a hospital system or a large multi-specialty practice, is getting people to take it seriously and say, this is going to be a priority for us. That's a lot of it, but also too, just the way that health insurance works, you puts unique challenges. So, when we talk about data in the insurance world, basically we have claims, and we have maybe authorization requests or something. Well, claims can be anywhere up to 90 days in arrears typically. So they're great for describing what happened a few months ago, but they're not really helpful in terms of telling you what's happening today. And, I've argued with many people and probably irritated quite a few of them, actually, I think, about the value of predictive models for, who we should contact next week based on 90 to 120 day old data. Like, you can't do that. You can make general assessments of maybe whose population's a higher risk, but that data will not tell you who do you need to speak to today. And so there is a huge time lag in a lot of the healthcare information. So that and healthcare information deteriorates in its value over time. So solving the time problem. So that's where getting closer to like admission, discharge, transfer data from hospitals and emergency rooms so that you can know when somebody walked into the ER. That tends to be real time. Pharmacy claims are real time. So there are some transactions that are real time. Blue Cross Blue Shield, our Blue Cross, we have adopted a behavioral health service called Learn to Live. So this is online. People go in either single sign-on through the web portal or on their app, and they'll take a PHQ-9, a CAD-7, some other scores, ask questions about insomnia, and they'll get anywhere from you're doing fine to live coaching with master's level people. It's not therapy, but it's free. You can do it anytime. But we're now receiving those PHQ and GAD scores as clinical data. If in a health plan, in theory, if we can aggregate those scores from different areas, that could actually allow us to do a lot better job in targeting resources to people who need them, instead of just kind of creating, here's 10,000 people that you might need to talk to in the next 2 months. And so solving those kinds of logistical problems are huge, because we do have clinical data. It can be very valuable, but getting it organized and sorted is really difficult. We pay about 1 billion claims a year, I think. Maybe I'm understating that. But just understanding the billions of data points that an insurance company has, really filtering them, sorting them, trying to solve for which ones are the most valuable, and how to get them in a timely way, in a way that makes sense. Those are the biggest issues that we have. And also too, we want to make sure that we're tracking and we're paying things and pricing things correctly. As, the codes change every year, and making sure that all of that gets updated across all of our systems this is something that health in the insurance industry, things just never stop. And it's not that they don't stop operationally, they don't stop changing. And what you were doing last week, you may be required to completely change direction this week because of some regulation or statute. So it is a chaotic industry, which my background psych-ER, so chaos is fine. I kind of like it, but a lot of people don't.
Excellent. So Casey, as you know, we've got to have multiple stakeholders working together to have successful integrated programs, payers, providers. Tell us a little bit about how Meadows is supporting and advocating for these kinds of partnerships.
Yeah, thanks for that question. My 20-year career really has been built upon bringing seemingly disparate stakeholders and perspectives together. And I really do believe that that's when we find better solutions and are able to drive innovation, when we have voices at the table that maybe it's the first time they've even been in the same room together, much less where in the world do they align. So, as I mentioned earlier, we have the good opportunity, the good fortune in many ways to be able to be working with providers We work, with consumers, and we also are working with health plans and are able to try to integrate the various perspectives. At the Meadows Institute, we do believe conceptually that there needs to be a total overhaul of how we think about risk detection and treatment for behavioral health. As Frank mentioned earlier, we do believe mental health, behavioral health should be treated like the rest of our health, and that is in detecting early signs of distress and risk in primary care settings. And data tells us that really that collaborative care specifically is the most robust model clinically for better clinical outcomes, but also has the financial sustainability that we need today in order to offset the trajectory that we're on in this country. And, depending on who we're talking to on any given day, sometimes those financial outcomes are more important, and sometimes those clinical outcomes are more important. And, based on our real world examples throughout Texas, we're able to build on, foundational research from the AIM Center and around the country to provide insights on what it actually takes real world. So for example, we're learning that, implementing collaborative care in primary care settings can be, with fidelity to the model and technical assistance, can be cost neutral at around the 6 to 9 month mark, and even cost savings at around the 9 month to 1 year mark. We're also learning that psychiatric time that's so valuable, if you're going into a practice that's incredibly busy, psychiatrist in a year can see 3 times as many patients as a traditional outpatient setting through the collaborative care model. And so, we're really thankful to be able to have the foundational research and to be able to build on it with our real world experience, and to have the perspectives of the various stakeholders that it is going to take in order to transform the infrastructure that we have. And we welcome other partners to come to the table with us and really lead so that we can try to address some of the real challenges that we're facing in the country. We were an overburdened system before the pandemic. We know the first signs of distress happen 8 to 10 years before they're picked up in our current model. And we just can't sustain that as a country for very much longer.
That's remarkable, really exciting. And I hope all can see that there's huge opportunities for scalability. I mean, that's just 3 times as much psychiatry time. Very exciting stuff. So another thing that is quite exciting for me personally, let's pivot over to the technology aspect. Tom, you talked a little bit about how technology is an important component to enhancing access and also measuring the quality of care that's being delivered. Can you talk a little bit about what is your approach at NeuroFlow?
Sure, I'd love to. So part of what we have developed at NeuroFlow is the ability to screen patients for depression through a mobile health platform, an app. So that app allows people to complete PHQ-9s and GD-7s from the comfort of their homes using their phones or a computer. There's also AI-guided journeys and content based on how people are scoring on those assessments, so they can actually get some benefit right away from interventions before they even see the primary care doc or in between appointments. Those scales are then populated into a registry that is available to the clinicians if it's a collaborative care model integrated in the primary care practice. It's available to the primary care docs, and information from that registry, critical information from that registry, can also populate into the EMRs. So we have that interoperability, so we can populate, whether it's Athena or Epic or other EMRs, we can populate information directly into the EMR. So it becomes a pretty seamless transition for the physician to be able to see how their patients are doing. They're not overly burdened by it, because the other thing that we do is triage. So we can take these scores and include a number of other metrics and create a severity score. So we can really identify who is really at high risk and create what we call either urgent alerts for those where there's an immediate safety issue, if they're endorsing any suicidality, whether it's on question 9 of the PHQ-9 or whether it's through journaling that they do through natural language processing. We can identify when someone has endorsed something that is dangerous or harmful, and that will immediately send out notification to the patient about resources for them. And then we can also alert clients, whomever is designated. We also have the ability to, for clients who work with us, to have what we call response services. So we will respond to those urgent alerts as they pop up. There are also at-risk alerts. So patients who are not at immediate risk of self-harm or harm to others, but there may be some reason that they are not doing as well. Their scores are declining, they're deteriorating. There are these at-risk alerts so that when the primary care doc or when the caseload supervising psychiatrist meets with the clinician, the care manager in the practice, we're really able to identify those individuals who are at highest risk, those 5%, who account for 50% of all healthcare costs, and where 60 to 80% of those individuals have psychiatric problems. We can really identify who those individuals are through this risk severity scoring, and then see how they do over time. So no one falls through the cracks. This is all automated, so it unburdens the primary care doc. It doesn't require people at the front desk to hand out pen and paper assessments. For those who don't want to do the assessments through the phone, there can be a kiosk or a tablet that's used in the primary care practice. And then, of course, there's the fact that there's a shortage of providers. So when you have the ability to offer digital health solutions, so in other words, telepsych, when you can have a pool of providers who are available when the local resources are limited, that's something else that we provide and can provide the management if our clients need to have that. So it's a combination of technology and management. It's not technology only. It's technology and high touch. It's that hybrid, the combination of the two that can make a pretty profound difference and enables the workflows to work in a way that allows healthcare systems and payers and others to scale this on a much, much larger scale. And one of the things we do at NeuroFlow is we look at our results and we track them and we validate them. So we're constantly looking to present and publish our work to demonstrate that it's effective. So those are some of the things that we're doing.
Fabulous. That sounds hugely promising in terms of scalability and really exciting to hear that. I want to make sure we have enough time for questions here. So I'll just real quick, Frank, do you have some ways that providers can get quickly engaged in collaborative care?
Sure. I mean, well, quickly, that's the operative word. Number one, especially if you're a primary care physician psychiatrist and you're doing measurements, there are CPT codes for that. You may have to bill a Z code for showing that you reviewed a given the standardized assessments, but those are billable, and just you can actually Google how to do that or talk to your coder or something like that. That's the first step, is just get used to that and have a good platform like Tom's talking about, where your patients can fill them out online, or they can use an iPad or something in your office. I'm an Apple guy, so couldn't be an Android kind of thing, but in general, start there, right? But if you're looking at collaborative care, number one, you can look to hire groups. You can hire if you're primary care, you're looking for behavioral health practitioners who are experienced in this. Those CPT codes are there. They were published by CMS in 2017. So they're billed monthly in kind of like hour-long increments. And they reimburse fairly well. So those codes exist, and they're really designed to help the medical group pay for the expense of those behavioral health practitioners. There's multiple ways to bill it. So if you're not sure, you can talk to your health plan partners, et cetera, because some of them, we've talked to people about many different arrangements where the medical group pays the behavioral health practitioners, the medical group bills us, or the behavioral health group wants to bill us, or, there are all sorts of ways to do this. But just understand that there are things out there to support it. And like Casey's talking about, especially in Texas, there are startup costs, and there may be some funding, through philanthropy to help with some of the startup costs to try to advance collaborative care. Large systems probably don't need that, but if you're an independent group, mid-sized group, you probably do, and probably want the expertise and advice of, because you want to do it quickly and well. You can do it quickly and get it wrong, which is expensive. Pulling in the outside expertise, if you're not really familiar with this kind of implementation, will really make a huge difference too.
Excellent.
So I'll just underscore that. I know NeuroFlow also does some technical assistance when they start working with provider groups. We do too. We've had the bad experience of going into a system who's been trying to implement without the technical assistance, and it can be much more efficient. Like in the end, there's ultimately cost savings if you can have someone come in, even in a small scale, and provide some technical assistance, because the workflow shifts they're difficult, and they're unfamiliar to many practices, and change is hard for all of us. So, I think I just want to underscore what Frank, and I think Tom mentioned it earlier, that investing in that technical assistance up front really does go a long way. And I'm actually really excited. We're looking for ways to partner with NeuroFlow and other orgs to figure out how we can optimize the efforts that both of our organizations are undertaking already, so that we can try to help more practices and more people get access to the collaborative care model and integrated care overall in the future.
Yes, I'm thrilled about that. More providers becoming aware of all of these opportunities. I think we're all equally excited about that. Let's see, with the few minutes that we've got here, such a great discussion, but I want to make sure we get some questions. Let's see. We've got one coming in. What's the general impression of the mental health chatbots and other virtual tools that offer some level of therapy counseling when a live clinician is not available? And how do peer counseling groups fare in comparison? Anyone want to take that?
Well, I'll take a stab at that. There's not an overwhelming amount of literature comparing certainly digital interventions to peer supervision, but there's a growing body of literature looking at the effectiveness of sophisticated AI-driven digital interventions. We've recently published a number of things, and actually just submitted an abstract looking at primarily digital interventions using a range of things, including CBT interventions digitally, to see how that can make a difference for patients. And what we're finding is it really can. So, this is not to suggest that digital interventions can replace a psychotherapist, but they can make a very big difference. And the thing that it does is it extends the practice. So in between appointments, when you have AI-driven content, patients can do exercises, go on content journeys, review educational materials. There are medication adherence, a whole range of things. So that's the one way that I can try to answer that question.
I'm going to second that too, actually, because part of what we did with Learn to Live was thinking about, okay, what do people who maybe don't have a full clinical syndrome of depression or require treatment for anxiety, what would they need, right? Because this is where, maybe the person doesn't actually need formal therapy or formal treatment, in which case those digital tools and the kind of stuff that you can do on your own time at your own pace can actually help in the coping skill building, et cetera. They're based on sound cognitive behavioral therapy techniques. And for those that are in treatment, like you said, as a practitioner, it's like, I wish I had 5 or 10 years ago these kinds of tools to tell people about. and just that ability to support stuff in between treatments. So I personally think there's a really good use for people who don't necessarily rise to the level of needing formal treatment, but for those that do, it actually is a great adjunct. So it's got broad applicability, which is actually hard to find in a lot of things. You know, something can be useful in a wide range of situations. This stuff actually can. It's really cool.
Mhm.
And I'll just add, Frank actually led today's conversation with this point, and I'm just looking at the time. I would love to finish, or at least my comment for today, finish in that there are so many solutions or innovations that are out there, I think is probably the better way, but where there's just missing largely across the board with all of these digital innovations is the measurement component. And, you know, I would encourage you, as you're trying to figure out how to extend your workforce and how to get people tools in between sessions, to really prioritize those tools that are measuring the outcomes and the impact of whatever it is, because that is a huge gap. You know, the innovation has really outpaced the quality aspect of the behavioral health field at this point.
Yes, I couldn't agree more. Wow, we got so many more questions, which we will capture them. I will follow up with everybody. You can expect a follow-up email with the recording. I only wish we had more time. I want to thank our amazing experts to be with us today and really appreciate these fabulous insights. Thank you, everyone, for joining us.
Thank you so much.
Thank you.